guidance. But as always, I want to preface this by saying we constantly get new guidelines from CDC. We constantly develop new structures for other congregate livings in nursing in Maryland as the world changes because of vaccines becoming more available, or cases going down, or cases going up. So unfortunately, what I'm about to say isn't going to be the answer to all of your questions to the end of time. It's just going to be what we're recommending right now. So, okay. So first, I just want to talk about what is the guidance for the general public. Okay, before we get to DDA, what is the guidance for the general public? Okay, so for the general public who do not live in healthcare settings, okay, fully vaccinated members of the public who have close contact with someone with COVID-19, they don't need to quarantine and they don't need to be tested. You may choose to do one of those things, but you don't need to do those things. The CDC says they're not necessary. For people who are not fully vaccinated, and if you have close contact with someone with COVID-19, you should go be tested for COVID-19. And you should do a quarantine, ideally for 2 weeks. CDC's got some options they talk about for shortening quarantine, but throughout here, we're just going to assume that it's a 2-week quarantine because that's always the safest choice. There are options to shorten it, but 2 weeks is sort of the gold standard. So again, with the general public, the quarantine recommendation depends on vaccination status. If you're vaccinated and you're exposed, no need for quarantine. If you're not fully vaccinated and you're exposed, recommendation is be tested and do a 2-week quarantine. And throughout this, when I use the word quarantine, I'm going to use it to refer to people who are not infected with COVID-19. In other words, you're taking yourself away from others preemptively because you were exposed and you might become sick. That's what I mean by quarantine. Okay. Somebody ever actually tests positive for the virus, I'm going to describe that as isolation. Okay. Which looks the same, but we use that different word. Okay. All right. So that's for the general, that's for the general public. That's what the guidance is for the general public. Okay. And in fact, that's the guidance that we encourage group home staff to follow if they happen to be exposed to COVID-19 outside of work. If your staff are fully vaccinated and they get told by a health department, they get a call, hi, we've just learned you had close contact with someone with COVID-19. They're going to ask, are you fully vaccinated? And if they are fully vaccinated, they're not going to be required to quarantine. And if they're not fully vaccinated, they are going to be quarantined. And let me pause there. Do folks know what I mean by fully vaccinated? Let me just quickly review.
It might be worth a clarification to be sure.
Sure. So when I say fully vaccinated, what we mean is you've received all of the scheduled doses of a COVID-19 vaccine series, and then 2 more weeks have passed. Okay? So, for Pfizer and Moderna, which are by far and away the most widely used vaccines here in Maryland, that means 2 doses. You've had your first dose, you've had your second dose, and then 2 weeks have passed since the second dose. That's when you're fully vaccinated. Okay? So throughout this talk, whenever I say fully vaccinated, that's what I mean. And whenever I say not fully vaccinated, that means everybody else, even if you've had 1 dose, even if you've had 2 doses, but you're not 2 weeks out yet. Now, what about the Johnson & Johnson vaccine? So that one's a lot less common, although I anticipate it might become more common because it's a very effective vaccine. Johnson & Johnson vaccine only requires 1 dose. So if you get the Johnson & Johnson vaccine, 2 weeks after that 1 dose, you're fully vaccinated. Okay, so that's what I mean by fully vaccinated. Okay, now let's talk about DDA. So what the CDC has is they have separate guidelines for people who live in a healthcare setting. And throughout the pandemic, we've tended to err on the side of treating group homes that serve adults with intellectual and developmental disabilities as healthcare settings for a couple of reasons. One, because in their homes, they are regularly receiving care that requires a high degree of close contact from professionals or paraprofessionals who are taking who to keep themselves safe, need to take the kinds of precautions that are taken in health settings. And 2, because people who live in group homes for adults with intellectual and developmental disabilities often have co-occurring chronic medical needs. In other words, they're more likely to have the kinds of needs that come up in other healthcare settings like nursing homes, that kind of thing. And so, for healthcare settings, there's a stricter standard for quarantine. And this comes about because the vaccines are not 100% effective. They're highly effective, but they're not 100% effective. And so we take extra precautions in a healthcare setting where the risk of the virus spreading is very high. And if you get infected, the risk of something very serious happening to you is higher in a healthcare setting. So what that means is that for residents of group homes, okay, we recommend a 2-week quarantine regardless of vaccination status if you're exposed to somebody with COVID-19. In other words, if you live in a group home for adults with disabilities and you're exposed to COVID-19, you should stay in your room, not participate in activities outside the home, stay away from others for 2 weeks, regardless of your vaccination status. Okay. And that's, if you're exposed to somebody with COVID-19 at your job, at a day program, at something outside the home, right? Then you should quarantine in your room, away from your roommates. And that's regardless of vaccination status. And the reason for that is because you live in a healthcare setting. Now, in addition, there's an additional requirement for residents who are not fully vaccinated. Okay. And this is based on the standard for nursing homes. Okay. So for residents who are not fully vaccinated, we are recommending that people quarantine if they spend a night in the hospital or if they spend time sleeping or dining in the homes of family or friends. Okay. In other words, you go outside the home and you're not fully vaccinated, you could potentially be exposed to the community. We don't want you to bring that back to the other people who live in your home and also back to the staff who live and work in that home, potentially putting them at risk. Okay. So you can go out, you can visit your loved ones, but you have to do the quarantine when you come back. There's no recommendation for quarantine for the fully vaccinated residents when they go home and they visit their family or friends, or if they need healthcare that requires them to stay in the hospital. There is a recommendation for testing, and I'll come back to that at the very end because we recognize that's been a challenge. Okay, so in summary, members of the general public, including your staff, they're exposed to COVID-19 in the community, they're vaccinated, they don't have to quarantine. Residents of a group home, they're exposed to COVID-19 in the community, even though they're vaccinated, they do have to quarantine because they live in a healthcare setting. And in addition, if you are unvaccinated and you live in that group home, we're recommending you do a quarantine if you spend a night in the hospital or you spend time sleeping or dining in the homes of friends or family. That last requirement, not required for vaccinated residents. They can go home, they can visit their loved ones, come back, life goes on. Okay, what happens if someone who actually lives or works in the home tests positive for COVID-19? In other words, somebody who lives in that home has now actually tested positive. They got sick and they tested positive, but they were tested for some other reason. Okay? Then it's back to the same outbreak precautions as always. Nothing has changed. Okay? The person who tests positive needs to go into isolation. Okay? They stay in isolation for 10 days, plus any additional time that's required for them to recover. All the residents, regardless of vaccination status, 2-week quarantine, and should be tested for COVID-19. All the staff, regardless of vaccination status or PPE use, should be tested for COVID-19 and should stop working in homes that aren't currently experiencing a COVID outbreak. In other words, they could be infected, so we don't want them spreading it to other homes. Okay? And there's an additional stricture. So the idea for staff is if they're using their personal protective equipment properly, it should be protecting them, even if they are not vaccinated. But if they did not use their personal protective equipment properly, and they had close contact with somebody who had COVID-19 while working in the home, they didn't wear that personal protective equipment properly, and they're not vaccinated, we recommend they be excluded from work for 2 weeks. So we don't recommend staff exclusions unless the staff are unvaccinated and they didn't wear their personal protective equipment properly. And I'm happy to talk about what that means in terms of personal protective equipment. But basically, that's the same guidelines we've had all along for what happens when somebody in the home actually tests. Okay, and that's because once someone in your home is tested positive, it's a whole nother world, right? So now we're in a world where everybody's at high risk because of the prolonged close contact you're likely to have with people in your home because you're sharing staff with people in your home. We want to nip that outbreak in. Okay, so a thing we get asked about a lot is what is required when vaccinated residents go home to visit their friends or family. So our current guidance recommends these people be tested for COVID-19 immediately before or just after returning to their group home, and that they do a brief quarantine until they have their test result received if they didn't get that result back by the time they get home. Okay, and this is the number one thing we hear concerned about because they say it's a significant unnecessary barrier to visiting loved ones for vaccinated persons. And we hear that, and we're actively reviewing the guidance to see if it's still appropriate. For the moment, it still stands, but we've heard you, and we're actively reviewing to see whether it's still appropriate, particularly in light of some changes that CDC made. But for the moment, I would just note that if this is a barrier, a rapid test would satisfy this recommendation, which would obviate the need for quarantine because you'd have the results in 15 minutes. So, for the folks who are fully vaccinated, they go home, they spend a night sleeping in or dining with loved ones. Right now, we're recommending they get tested out of an abundance of caution. They want to stay in quarantine until they get that test result back, but you can do a rapid test, get that over with right away. And we are reviewing that. So that was a very long answer, but I tried to be as thorough as possible. I hope it was helpful, and I'll stop there.
Thank you so much for that. And you did mention as you were speaking a couple of things that were exactly the points that came up as you were talking about, just a little bit more clarification. One you just started to allude to, which was the quarantine and testing. And so I think that you've hit that, but I'm going to ask it again just to make sure that the person who asked that question knows they're acknowledged. And that was, for someone who has been quarantining, maybe they've been in quarantine 5 to 7 days, they get the test result and that test comes back negative. What then?
Yeah, that's a great question. So, I mean, for folks who live in healthcare settings, they should stay in quarantine. Yeah, because we have these very, very stringent standards for people who live in healthcare settings. We don't recommend allowing people to test out of their quarantine, because you're correct, 5 to 7 days after your exposure, if you test negative, you're most likely not infected. But sometimes people fall through the cracks. And the point is, if you just live in the community and you fall through the cracks, the stakes are not as high. But if you fall through the cracks in a group home, you're living with multiple people who are potentially at high risk for severe COVID-19 illness, and you're having close contact with your staff person, who is potentially putting their health and safety at risk by working with you if the quarantine guidelines are changed. And I want to touch on something that's related to this that I think is really important, right? So all of these guidelines, they reflect what we know about the virus, they reflect what we know about the vaccines, but a really, really important part of this is they also reflect just how common COVID-19 is, right? So even though we're in a much, much, much better place than we were now, COVID-19 is still out there. It's still pretty common, okay? When COVID-19 is rare, that makes us all safer, right? Then we can lift restrictions or guidelines simply because the virus is not really out there as much. And so you're unlikely to get infected if you just do the things that we used to. Okay, so the hope is that by widespread vaccination and continued use of caution, the virus will become much more rare and we can continue rolling off these things. So, that's just important context.
Thank you. And the other question that came as you were talking, you also mentioned proper use of PPE and the importance of properly wearing that PPE. There was a question about how does that look in an organization or a residence where there's high vaccination compliance? For example, is the face shield still a requirement if there's high vaccination compliance?
Yes, and that may change, but I can tell you the first things that we're rolling off, right, is we're trying to allow, basically people to return to the essential activities that they want to be able to lead their lives, right? Go back to their group home programs, right? For staff, and we can talk about this, but for staff to be able to go outside the home and take their masks off if they're fully vaccinated and eat, when they're away from the residents. But in terms of the personal protective equipment that people use when they're actually providing direct care, those will probably be some of the ones we walk back later, because we recognize it's uncomfortable and burdensome, but to be frank, we want the staff to be safe. And when one staff keeps themselves safe, they also keep the people around them safe, right? Because if I protect myself from getting infected with COVID-19, I'm also protecting you from getting infected by COVID-19. So for the moment, yes, the face shields continue to be required. And I just want to say, I see a question here, follow up. Then if quarantine status doesn't change with the negative test result, why test at all? Because if you test positive, we want to know, right? So if you test positive, right, then you're going to need to go into isolation for at least 10 days, right? Which could extend the period you're in isolation relative to what the quarantine is, right? You would know in advance that that person is tested positive, and you could prepare, you know, for their healthcare accordingly. If they've had close contact with anyone else, it gives you the opportunity to do retesting, right? Because you say, okay, now we know COVID-19 is spreading in the home. We can test other people. Yeah, so it's because if you test positive, that's valuable information to you and to the people around you. So the testing is really to understand if the virus is spreading in the home. And finally, I think, and this is something we don't touch on as much, COVID-19 is, you know, so those are the most important reasons why we still require testing, even if it doesn't lift the quarantine requirement. COVID-19 is a new disease. And so we just don't know what its long-term complications are. It's only existed for 1.5 years. And so we can't know that much about what it means if you've been infected with the virus that causes COVID-19 over the long term. We think most people make a full recovery, right? That for most people, it's not that serious an illness. And it's only for some people who it becomes extremely severe, which is why we've had this disaster we've had. But we don't know. And so I think it's to your benefit to know if you've tested positive for COVID-19. Because if we find out later that there are health complications associated with COVID-19 that we didn't previously know about, that's on your medical chart. And we say, oh, you know, you've started developing these health complications. Maybe that's attributable to the fact that you had COVID-19 back during the pandemic. Maybe we can help you. Maybe we can do something about it. So there's also just a right to know piece here. It's good for people to know if they had COVID-19, if they did have it. Okay.
Thank you so much. You've covered a lot in that answer, and you know, really appreciate the detail, and also appreciate, you know, some of what you've mentioned a couple times. This is an evolving situation. Some of the things will be, you know, reviewed as things change, and so that's part of our job in this collaborative is certainly trying to sort of keep in touch with you, make sure that a lot of that information is being translated and out into the community. So really appreciate your response there. I do want to move on to the next question, because, you know, the weather is improving, people are getting vaccinated now, and there's a lot of excitement about being able to get out into the community and possibly out to other countries. I'm sure you know, here in Montgomery County, we have a very diverse population and many people who are foreign born and may have families overseas. So what is the DDA guidance with regard to travel to another country? And does travel guidance vary depending on vaccination status? What types of things really should the service provider organizations be thinking about as preparing their policies and procedures for staff who may want to travel?
Sure, this is a much easier one. There is no DDA guidance related to travel at the moment. There is CDC guidance related to travel, but, you know, it's not, it's recommendations, right? So basically the recommendation is if you travel internationally, okay, CDC recommends you be tested for COVID 3 to 5 days after returning. And if you're not fully vaccinated, CDC recommends that you be tested for COVID-19 3 to 5 days after returning and do a 7-day quarantine before returning to work. Okay, so, you know, it's up to you as a provider how you want to deal with that, and I'm going to paste a link to that in the chat. It's up to you as a provider how you want to deal with that, you know. But so basically, if your staff travel internationally, you can encourage them to be tested for COVID-19. There's no written DDA guidance about this, and if they travel internationally and they're unvaccinated, you know, at your discretion, you could choose to ask them not to come to work for a week. Okay, so that would be the CDC recommendation, is that if you travel internationally and you're unvaccinated, the recommendation you do you wait 7 days before coming out of a self-imposed quarantine. But, you know, there's no Maryland or DDA specific guidance about that. And we recognize international travel is something that your staff want to do, and that Montgomery County is a very diverse place and people are going to be leaving the country. You know, what I'll say is the vaccines are extremely effective, and we're very lucky for that. So I expect them to be effective most places in the world.
Great, thank you. The next question that came in, and I'll let you both know, we did a little brainstorming last week to think about what questions would everybody want to ask you, and so that's the source of some of these questions. So they weren't all immediately added to the chat. Some of these were pre-planned, but it really relates to transportation locally, and thinking about, as day programs are opening, as supported work sites are having more people coming in. Are there recommendations for social distancing in terms of how we get from point A to point B? We recognize that keeping social distance in a bus or a van, that's not really going to work. So
Yeah,
what's
I
the
hear
guidance
you.
there?
Yeah, it's a great question, and I appreciate you helping me. This is one I'm very glad I had advanced because it's something we don't have guidance on, but CDC actually does have guidance on, and I wasn't even familiar with it myself. It's not super detailed, but the crux of it is, everybody who can wear masks should do so. As much as possible, limit close contact with the driver. The more you can social distance in the vehicle, the better. Recognizing it's not always fully possible. And then I think the key one that a lot of people miss is boost ventilation in the vehicle. Okay. So that means cracking the windows of the vehicle at all times, and or setting the air conditioning to a non-recirculation. In other words, we want, the way we're still learning about how this is not, I want to preface this with the bioengineering aspect of this is not my area of expertise. Okay. But, we know COVID-19 transmission is much higher risk in indoor environments where air doesn't circulate than outdoor environments, all other things being equal, including close contact, right? So it's just much riskier to be indoors or in a contained environment for extended period of time. And the reason is that what happens is that as people are, when they're sick, the virus is coming out of their mouth and the nose in respiratory droplets, and then it's dissipating into the environment, and it can hang in the air in short distances for short periods of time. And in a contained environment, that can build up over time as people keep talking or coughing or shouting or whatever it is that they're doing. Okay. But outside, it just dissipates into the environment. It's much less likely that me as an unsick person, I'm going to inhale enough of those virus particles to actually get sick. And so circular air ventilation and circulation really matters. And so first of all, right, so the best way to protect your residents in any setting is by promoting vaccination, and you guys are doing a fantastic job of making sure your residents are vaccinated, right? So that protects them in every setting. If they're driving in a crowded vehicle, particularly if some of them won't wear masks, that ventilation piece I think is the next key step. Are staff required to wear shields in vehicles? No, I don't think so, because they wouldn't be providing close contact care to their residents, right? So they would be driving and the residents would be in there, but there's no risk of like splashes or sprays or it getting in their eyes. So if that's really for like direct care activities. I think the answer is no, they're not required to wear face shields in the vehicle.
And it was also noted that could potentially be a driving hazard if you
especially because it's driving hazards, and I get that. We don't want folks driving if they can't see. Yes, but that's a good question, and that's probably something we should clarify written down. And in general, I think something we owe you is clarification about activities outside the home. My focus this whole time has been on everything we can do to keep people safe in their homes, and then say, the safest choice is to stay home. We don't want to live like that anymore, and we get that. People want to go be able to live their lives again, and because of vaccines, they should be able to. It's incumbent on us to try to keep working with you to come up with ways that people can live their lives safely while they're not at home. So these gaps and questions about transportation, international travel, I hear that. Hopefully some of the CDC guidance will be helpful as guidelines.
Great, thank you, and we appreciate that. And I do want to remind all of our participants, as you have questions, please do go ahead and drop those in the chat. The team is monitoring the chat, and I hope some of you have heard your questions asked and answered. Next one that I had on my list is regarding whether there's any likelihood of requirements from state agencies concerning the vaccination status of individuals with disabilities as they begin to re-engage in full community activities, and whether that's something being contemplated at all. So is there any requirement for residents to be fully vaccinated before going back to day programs or supported work sites?
So I think that question's for me. This is Bernie Simons. First of all, let me start by thanking everybody who is on today, who probably participated in they started out weekly, every Friday, talking about COVID. We had the opportunity to have Dr. Fetter on with us multiple times. Some of the providers who basically from different parts of the state came in and did presentations about what the challenges were and what the success rates were and things that they were doing within their agency. So again, let me start by saying that. So currently there are no requirements from any of the state agencies to mandate, and I'm interpreting your question as mandate. It is a choice. We know that. We've been talking about this on our weekly calls, webinars that we went to every other week, not that long ago, and it is a choice. We will not, in DDA, be placing any mandates, and we know that the governor has been out and talking about all hands on deck effort, and especially with the COVID-19 campaign called No Arm Left Behind. You see daily that there are new mass vaccination sites that are opening. I think it was number 13 that opened a week or so ago. We've got more that will be opening. There was a press release a little while ago today, earlier, that basically talked about going around and doing testing, not vaccinations, testing, and having mobile testing for people. So I'm not sure what else to say, except we may get further guidance in the future, but DDA is not the public health expert. That's why we have people like Dr. Fetter in our public health administration with our Deputy Secretary Chan and the epidemiologist, et cetera, that we work with.
Thank you for that clarification. I think that it is very helpful to know that that's not something that's necessarily being planned at this time as a mandate. So that's very reassuring to many, and many others may feel differently about it. That's one of the things that makes this topic so complex. A quick follow-up, because you did talk a little bit about testing in your response. There was a question about, frequency of testing, and I'm not sure which of you is the best to answer this, but what's the recommendation for continued frequency of testing, sort of appreciating what was said about the importance of doing the testing, but, do we keep on with weekly, or does the timing change?
Sure, that's a great question. So some providers have been proactively choosing to keep just regularly testing their staff and residents with no other reason other than just a turn up case. So we are no longer requiring that for, you know what, I'm going to stop myself. I think we are no longer requiring that for vaccinated persons in nursing homes, but I'm going to double check that and reply after the webinar so I can give you guys an accurate answer. But in general, I think particularly for vaccinated people, that kind of regular testing over and over again is probably not necessary. Only if there's an outbreak in a home. That's when we want to start testing vaccinated people. For unvaccinated people, we haven't required repeat testing in group homes because of the, logistical challenges associated with it. But if you are doing it, continuing to provide that to your unvaccinated staff, or required for your unvaccinated staff, I think continues to be advisable because COVID-19 is still coming. And so if you are unvaccinated, you remain as vulnerable as you've always been. That repeat testing is helpful for catching cases that might otherwise be missed and keeping it out of the home, keeping it away.
And it's a great opportunity for me to give a shout out to the organizations here in Montgomery County, because I know many were able to institute a routine testing program. And so that's just a little praise for our community here. I'm sorry, one moment, my assistant is chiming in.
You have a very cute assistant, may I say.
He has a future in public health because he's telling me about his great idea to help people get the vaccine quicker. But for now, the next question actually is not specific to that. It's actually about understanding the quarantine as it relates to billing. So this question is, since the recommendation is to test a person after a home visit with family and then wait for the quarantine for a few days for those test results to come back, can that provide bill that as a COVID isolation day while they're waiting for the test? And that was a question that just came into the chat.
So I see that question, and I would refer you back to the Appendix K guidelines. I mean, I think it's very clear. You know, we followed everything that came out when we applied for the Appendix K through Medicaid, got approval from CMS very quickly. And as we have been in this pandemic, there have been additional guidance that has come out from CMS. You know, I know that at one point we had looked for 30 days and then for relief for the providers. And then we heard back from CMS that we had to tie it to nursing home bed absence days, which was 16, I believe. And then we had further conversation and the numbers going up. So I would think that if you want the best answer with the most current information, I would email that question to Rhonda Workman.
And I just want to briefly chime in and say, you know, I want to be very as candid as I can be. We hear your concerns about that current recommendation requirement about testing after visits to loved ones for vaccinated people, and we are considering whether it is still appropriate. So more to come on that in the future. Yeah.
And the next question I had, and this is one where I will admit I really have a knowledge gap because of the space that I'm in. I'm sort of new to working with service providers in this space. But I do understand that some day service models are predicated on the idea of individuals being in the community for a certain number of hours in a day. And my understanding is that the same is true for example, for adult medical day, that there's sort of a certain number of hours that someone must be at the program. Are there considerations for allowing leeway to that in terms of the eligibility of the visit or the service, so that there could be a more incremental or phased re-engagement into the community activities?
Well, I think you've got to reflect back to 2014 when the Center for Medicare and Medicaid Services issued the community settings rule that talked about people being engaged in the community and not necessarily engaged in a quote, day type program behind four walls in the building for their whole experience throughout the whole day, that there should be integration and exposure to people who are quote unquote non-disabled, as well as not just being in with their quote other people with intellectual and developmental disabilities. I'd answer this by saying we really need to go back and look at what's in the person-centered plan. That really should be about the person's preferences. We know we hear a lot about family members who basically say, I don't want my son or daughter been home with me for a year. I don't want them going back into a congregate setting like a day program. So, I mean, there's a lot to this. This is not one size fits all. I think the providers have done an excellent job in identifying safety protocols. And again, there are certain areas that people may or may not feel comfortable with even re-engaging in the community, such as mass transit, etc. So, it's again, I think it's a case by case and an individual by individual. There's no set hours that someone really needs to be out in the community, and so. And so I think that that's the best way to answer that. Again, I don't think we are that strict. We know that when we did the Appendix K, we asked for an easement of the way we provide services. So people who were doing day program had to be in a day program in order to bill. We said we wanted the capability of doing remote, so that somebody could remain in their residential site and the provider could interact with them, and it was approved by CMS. And there's always as tough as the pandemic's been, I think it's been a learning experience for some individuals who may not would have experienced remote learning or interventions that were caused by the pandemic, with the day programs being closed. And now we have those people coming back and saying to us, I don't want to go back to a congregate. Can I stay with remote learning and what we're doing, because I enjoy that independence, for lack of a better term, and not necessarily needing a staff person with me all of the time. It still provides the capability to provide a bill and to do that service, but I think it's just a different venue than what we're used to with being face-to-face all of the time. And as a result of that, we've been looking at this for a period of time now, and we've done some work with DC, had a meeting with them a while ago. We have a company coming in to help us, and we're going to move forward with being an assistive technology first state, so that it's not just about, when we say assistive technology, people think about ramps or those types of devices, as opposed to what else is out there where people can become much more independent.
Great, thank you. And I think, just to summarize a little bit what I heard you saying, and to make sure if I understood you correctly, what I hear you saying is the person-centered plan leads, right? But recognizing that there are things that we've learned in the pandemic, it's been a terrible situation, but there have been tremendous learnings out of that. And one of those learnings is that maybe there can be more flexibility in terms of how we engage people. Some people might prefer that remote learning option. And so service providers can think about that in terms of the services that they might want to offer without having to be concerned about their operational sustainability and their ability to bill for those services.
Yeah, I agree with that. I think that the other issue that I'd like to mention is that, I hear from some of the providers that they are having difficulty in getting staff to come back to work, who have either taken other jobs, unemployment, or whatever. And as we start to ease and reopen and move forward, I think that it would be beneficial for the providers to think about remote supports, where you could maybe have one individual through either a camera or monitoring be available at multiple sites. Everybody doesn't need somebody for a full shift. We might need people intermittently. We've seen videos that other states have done that have basically said, all right, it's time for preparation for evening meal. You've got a staffer in a remote location who has 3 different cameras looking at 3 different individuals and assisting each one for a few minutes at each time with the steps going through meal preparation or whatever. I mean, there's multiple things. I mean, the only thing that's stopping us is our own creativity, I think, at times. And this has really been, as you said, beneficial. People have gotten, and individuals, families, and providers have gotten extremely creative in what they've done. And I'm really proud of a lot of the stuff that was done that I either hear back or the questions that we see in our webinars and the way people are engaged.
Lots of room for innovation. So that's great to hear. I'm turning now to some of the questions in the chat. Here's one that came in. CDC guidelines for the general public allow people who are vaccinated from different households to visit indoors without masks. One person raises a concern. Does denying this privilege to vaccinated people who are supported in the group homes amount to a violation of their rights to interact if fully vaccinated? Is there a risk that we're trying to mitigate when a vaccinated person wants to visit with his vaccinated or her vaccinated family members?
That's a great question. So I will be as to the point as possible. You're right, that's the guidance for the general public. CDC just published new guidance for healthcare settings that describe how to do visitation between vaccinated people without masks. I anticipate we will update the DDA guidelines accordingly. We understand that is probably one of the highest priority things, is that people want to visit with their loved ones. They want to go into their group home, go into a private room, take their masks off, live normal lives. We were following the CDC guidance as it exists before. CDC has updated their guidance. I anticipate ours will be updated accordingly to follow CDC. So I hear you 100%, and I anticipate there will be an update in that regard. And then I want to go back to a question that came up before, which is, you said, you're recommending testing people right after they get back from visits to their loved ones. If they're vaccinated, what's the point if it takes 5 to 7 days for the positive test to show up? So that's a fair question. It doesn't always take 5 to 7 days. So the idea is it provides an additional layer of security to do the test. You can always retest 5 to 7 days later. And we wouldn't recommend any quarantine between the first and the second test. But having said as much, we tried to strike a balance, may not be the right balance. And that's why we're reconsidering that recommendation, because to be frank, we think the vaccines are very effective we think the vaccines are very effective, and we want people who are fully vaccinated to be able to go home and visit their loved ones without serious imposition. So we're reviewing that. We'll see how it can be approved.
Wonderful. So I think we have addressed at this point all of the planned questions and those that I had scanned in the chat. And so I'm going to say a couple of things to wrap up in a minute. But before I do, I just wanted to invite Dr. Greenberg to unmute, since he worked with you both to invite you to this learning collaborative. And so we so appreciate you being here. And Dr. Greenberg, do you have any closing remarks? Yep, he may be struggling to find that unmute button, as I know I often do. So I'll go ahead.
I think he actually hopped off the call.
Oh, he may have had to tend to something.
Yeah, I think he hopped off.
Well, I will go ahead and share my closing remarks and reflections, which is really this. We call this group a learning collaborative. And I think that a lot of what you've shared with us today has provided clarification to many questions that we had. It's provided you an opportunity to hear those questions, to be able to sort of think about, well, gosh, how are things moving and shifting on the ground, as we know you do all along. And it really sort of highlights the importance of us learning together. These are unprecedented times. And while there's a lot of challenges that we have to navigate, as was shared, there's also a lot of room for innovation and for us to try new things and do things differently that might enhance the way we provide services going into the future and into the recovery phase, which we hope is very near. And so just really want to appreciate you both for taking the time to be with us today, to answer these questions, to have this conversation. And hope that we can all continue learning together and navigating the space together. And so Thank you so very much. At this point, one thing that I do like to do, because we're in the virtual space, we started out with the little hand clap emoji, but sometimes it's nice to hear a real round of applause. So I'd like to invite everybody to unmute your microphones at this point and give our guests a round of applause, please.
While we're unmuted, could he also answer Steve Keener's question?
Oh, my apologies. I must have missed
That's
that
fair.
question. So
Is this we're discussing guidelines for group homes? Does CDA recommend different guidelines for people receiving personal support services, more often living alone with just one other housemate, and it is their home? They hold the lease. Is that the question you're referring to?
Yes. Thank you.
Steve, I don't have.
I can take that.
Go ahead,
The
go ahead,
answer
go
is
ahead.
no, there's no difference. Whether the provider owns the lease or whether the individual owns the lease, it's about the interactions and the exposure of the individuals to someone else. I mean, we've got people who get personal supports in residential sites that their family, because they're living with their family, and the family says, I don't want you coming in. Supported living, again, is who owns the lease, not the provider, the individual. And so, yeah, people do live alone, but they still have staff who come in who may or may not have been exposed. So I don't think we really have any different guidelines. I don't think it's about the physical site as much as it's about the exposure of the individual and who they're coming in contact with. And after that, I'll stop and defer to Dr. Fenner.
No, I think that's a fair answer, but I think, I mean, what I'd just say, Steve, is that since we don't have written guidelines that deal with those situations. So I want to, when we came into this pandemic in public health, we didn't know that much about services for people with disabilities, and our background was, what we've constantly been doing is just trying to adapt the guidelines for people who live in congregate healthcare settings and figure about how they can be best served for people with intellectual and developmental disabilities who live in a very unique, different kind of congregate setting. People are changing the way they live now as we enter this new phase of the pandemic where vaccines are available. And I think that means we need to provide more structure and guidance for different settings, like people who are receiving personal supports in their home who are not living in group homes, or people who are participating in day programs. And we in public health and the folks at DDA are going to keep collaborating to try to provide more clarity about that. For the moment, one thing I'll just say that is a little bit different from the group homes, right, is the recommendation that I talked about requiring quarantine if you are fully vaccinated. Okay, so that's based on CDC guidance for people who live in healthcare settings. So if you do not live in a healthcare setting, you live by yourself in an apartment that you rent, you live in the community, but somebody is a home healthcare aide and they come into your home, there is no such requirement. And so if you're a fully vaccinated person with an intellectual or developmental disability, you live in the community, somebody happens to come into your home and work with you, and you find out that you're exposed to COVID-19 in the community, you can keep going about your life. There's no recommendation or requirement for quarantine for those folks who are not living in a healthcare setting. Now, having said as much, please keep coming to us with your questions about these other settings. That way we can keep thinking about how to best answer them and put it on paper so that we don't have to just say this stuff, or we don't have to say, oh, I thought that was, look at CDC, but we didn't have anything for you. So it is a learning collaborative, and we're learning too. I recognize that we've had 15 months and we are still learning. So I appreciate everybody's patience with us, our kindness. We are really trying to do everything we can to serve your clients and you.
Yeah, thank you.
Helping us learn with you.
I just want to say thank you that it's an extremely nuanced thing, because we're supporting some people, a total of 7 hours a week. It's not much different than if your housekeeper would say, I'm going to change your rules about your life because I come into your house every week, all the way up to people that are in our supported living that are getting 24/7 support. So the gradation, you have almost hit every spot along that spectrum. So I don't think there's a simple way to put it on paper.
There's not, Steve. And everything in services for people with disabilities is about individualized plan, right? And in public health, everything we do is about blunt averages. Because we have a responsibility to protect the health of the population through the tools that we have. And I mean, that's just the way public health works. That's how it's different than medicine. And those things are always going to be in conflict. And that is why we recognize that you are all at the end of the day going to exercise your professional judgment and do what's best for residents you serve, and give us the feedback we need to give the guidelines that we need so that people can operate within those strictures in a way that works in an individual. And Deputy Director Simons has always talked about those individual plans. I really appreciate that, because that isn't where my background is. And I think you're 100% right that that challenge is always going to be there. And that's why it's a learning collaborative.
Thank you so much.
Wonderful. And actually that exchange has pointed me to another thing to add to my closing remarks, which was, you talked a little bit about how it's really different perspectives, the focus on the individual and the person-centered plan, and then the focus on public health. Let's have a broad sweep to cover as much ground as we can. And I think that while that's really critical right now, while we're in the pandemic, bringing those together and sort of grappling through that tension will continue to be really important on into the future, and enable us as a community of service providers who all have the community's best interests at heart to do even better. We were doing okay before, we were doing well before, but again, one of the silver linings, because I'm always trying to look for those, especially in these dark days, is that this has really sort of pulled together those two sectors and points of view that have been quite separate. And so with that, I'm gonna let's do round of applause, take two. I thank you both very much again for your time. And if everyone would like to unmute to give our guests a show of appreciation and a warm send-off.
Thank you so much.
Thank you.
Thank you all.
Thank you.
Take care.
Thank you for the
Thank
opportunity.
you.
Thank you for the opportunity to join.
Thanks so much. Take care all.
Bye-bye.